Thank you so much, mostly for not giving me that topic. So thank you, Florence, for falling on that sword. Non-unions, hopefully we'll all have very few of these, but I think it's important because anyone who cuts bones for a living is going to have a few of these at some point. So we'll see what we can do. Disclosures, everyone's seen. So objectives, we want to recognize the non-unions after pelvic chest tabular osteotomies, be able to evaluate some of the local and the systemic risk factors for that non-union. And then as Florence just mentioned about correcting modifiable risk factors for whichever problem you're solving, anything you can do before surgery obviously is going to support the indication for surgery later. So anything we can do to make that environment better without surgery is important. And then restore the appropriate environment for fracture healing and osteotomy healing. So I did what anyone would do is I went and asked ChatGPT, what do we do for non-unions? And it gave me actually a very interesting answer, but I'm going to hide that for now. And then I said, well, that's stupid because the O in PAO is for osteotomy, so it's redundant. So these computers are getting there, but they're not quite as smart. So I'm not going to give you the answer that fast, but I will show you what it said at the end. Here's my case, patient of mine, BMI is a little elevated. We know that's a risk factor. Bilateral hip pain, right was worse than left. So we did the right PAO and everything went fine. She did great. About a year later, we go and do the left side. I'm thinking we'll just do a mix, an exact mirror image, get the right correction that we wanted. So here she is. And you can see on her right, I bring my own pointer here, her right, we had a nice union here. Everything seems to be remodeling. I did concomitant femoral osteotomies at the same time. And on the left side, everything's starting to go. This is about 3 months out, just still having a non-union at the pubic cut here. You can see with her obesity, everything was a little bit more challenging, as well as, I didn't mention this earlier, but we did have to bring her back, I'm trying to remember of which side, for some soft tissue wound healing issues. So here's the Lacane views for both sides. So I was reasonably happy with the correction and everything, but at 6 months, she's still having problems, and at this point, she's actually symptomatic. And so this is when we start talking more about how are we going to deal with this, because it's not something that I would think is, at this point, is not the expected course, although it might be. So what are the next steps? We want to get imaging, we want to get labs, when do we want to intervene? And so we start looking at what's the data for this. So we need to recognize non-union. So first thing is we got to do a good history afterwards and obviously figure out, are they having symptoms, making sure that the symptoms are evaluated the way that we want to with enough precision, and just talking to them. Really critical evaluation of the imaging. You want to see if any screws are displacing, any screws are fractured, any osteotomy sites that aren't as well remodeled as you might want them to be. Early on, I think there's a pretty limited role for advanced imaging. Everyone's always like, oh, should I get another MRI? And we've got 7 screws in the neighborhood, and I don't think that's worthwhile very often. And this might be for evaluation of what the non-union looks like, but it might also be for planning. If you're deciding we're going to intervene, obviously knowing how you're going to intervene is really critical. Risk factors, well, obviously this dovetails into a lot of fracture work, like many of the people who do open hip preservation surgery do a lot of fracture work. And so all the things that we can modify that are patient factors, so systemic things like smoking or other microvascular disease, they can get diabetes better controlled. And then local factors within the non-union site. So is it a stability and strain imbalance? Is there failure of fixation? You've seen maybe a screw's displaced, maybe a screw's broken, or something's moved. Maybe there's a new fracture that's a stress reaction somewhere, a posterior column injury or something. All these can create a different environment than we left the operating room with, and so that can be a risk factor as well. Then looking at what can we correct, right? So now we identified there's things. Is there ways from a non-surgical standpoint that we can? So obviously counseling, smoking cessation, using some of the different medications, or even nicotine supplementation, which seems to be better than actual inhalational smoking. Doing a good nutrition history about caloric intake. A lot of these patients are young female, and we know that social pressures that sometimes dietary intake is not what we would want. And then getting appropriate labs, and there's a million different things you can do for a non-union workup, but this is the basis of most of what we do. If you're going to get a real metabolic workup, there's a few others you can add, but that's generally where we start. A lot of counseling with the patient, and that comes to not only what we're seeing, but what maybe the expected course is, and that's where some of the data we'll talk about goes in. And then if there's non-invasive things we can do, and it seems like there may be a small advantage to using something like a low-intensity pulsed ultrasound bone stimulator. I don't have great experience with the magnetic field ones. They all get marketed, but with ultrasound, I think it's pretty low risk and reasonably high reward. If it does get you over the hump and unite that non-union, that can really be helpful. So what are the papers and what's the evidence? Most of this is out of core, and most of the authors are in this room. So we see that there's a varied experience, as you might imagine, but it's somewhere between a 5 and 17% asymptomatic non-union rate. So these are things found radiographically in asymptomatic patients, but somewhere between 1 and 8% symptomatic or even operative non-union rate. So it's not zero. I'd much rather be on the low end of that than the high end, and most of us are somewhere in the middle of that. And it depends on how symptomatic and whether you decide to operate, but that's a great number to quote that sort of ramps all these together. So we've got this 1 to 8% symptomatic non-union rate. And I think the most important thing is to understand the timing and the metabolic demand that there is to heal some of these osteotomies. And so really observe these patients and optimize them, because most of them are going to unite by 1 year. One study said about 90% of them unite by 1 year. So even at 6 months, it's not necessarily an impending non-union, but it's one of question. But really counseling the patient, saying, look, most of the time these do get better by a year, but if it's not better by a year, then we're going to do something. And so I think it's a balance of hoping it'll get better, and we like to counsel our patients on hope, and that's great, but our job is the planning, because we're all professional pessimists thinking about what's going to go wrong. So we got to give it time, but we know that at some point we're going to hit that point where we decide we're going to intervene, and it's nice to already know, at least to a reasonable degree, what you're going to do at that time. So here's our patient. I did decide to get a CT scan. I'm going to fly through it and I'll give you some key images, but most of the posterior column osteotomy is healed, and then we just have this non-union site at the pubis. That's where her pain was. It was all anterior groin pain. Surprisingly, not any symptoms laterally, no trochanteric bursitis or other things. So here's the slice, and we can see this gap here compared to where it's nicely remodeled on her contralateral side. Again, that's had a year head start, but still we're at a year and it's still not there. So this was something that we discussed. This also allowed me to reformat things in a perspective where I could decide what to do, because we might want to go see that non-union site and directly debride and bone graft, or we might just want to add stability. So when we're doing a non-union repair, is this something where you're going to just change the mechanical stability of the environment with implants, either plates or screws or a mixture? Or is it something where you're going to supplement biologically, do an autograft, do some sort of cellular allograft or something else? Can you take iliac crest? Are you going to go and take out the other implants so that you can get access to that? Maybe contralateral or posterior iliac crest, proximal tibia. There's a lot of different options for places you could get autograft. And then whether that area is something where you could reuse the same surgical approach, you're going to use a different one, you go to an ilioinguinal to extend the incision, or maybe do an anterior intrapelvic and bridge from the other side. It just depends on where your non-union site is and how you're going to get the best access to it, if the access is something you need. So in this case, I just used my combined obturator outlet view, and on the left hand, I'm just overlaying my guide wire to sort of prove that there's a straight line trajectory, that I can be extra-articular, but also intramedullary. And then I've got the guide wire here, which turns out the guide wire for some of these cannulated screws is also the core diameter of a large frag screw. So it's nice because you can put an over drill over that without having to find the hole multiple times. So I've got it across the extra-articular part of the joint. I've got it intramedullary here, measure out for my length, and she just gets an intramedullary screw across that with a lag by technique here, so I could over drill, and hopefully with some of the swarf created, we made it better. So here's what she gets. And 6 months after the non-union repair, now if you look the way her right superior pubic ramus looks, it's completely remodeled. So it's pretty impressive to me, just changing the mechanical environment, how much that was able to kickstart that healing process. And I just saw her, she's 4 years out on the left side and super happy. And she's actually did not know this happened, because the data seems to support the other side. She's lost like 60 pounds. So here's another case. This is a different part. Another patient, this one's about 45. She gets a left-sided paracetabular osteotomy. I'm reasonably happy with everything. And then about 6 months after, she comes in and feels this crunching noise around her iliac crest, and she's displaced her anterior superior spine fragment. I was kind of surprised about that, but The more you operate, the more you find new ways to make mistakes. So she ends up going back, and this one to me was not one that I wanted to wait on it. This was not going to move itself back into position. It's not going to create a better environment for fracture healing by waiting. So the minute I found this out, I counseled her. In my mind, something like this, where it's an anchor point for the sartorius and is going to get pulled out of place, I recommended surgery. And so she got the screws here out. We got a mini frag plate. I kind of went with like the automatic machine gun version of screw placement for as many as possible. And then she healed that, and about 9 months later requested it out because it is a lot more bulky and she's pretty skinny. So we took those out, and she had united it and was pretty happy. So what did ChatGPT say about this? Because ironically, when you read it, it's pretty accurate. It says persistent symptomatic non-union after adequate time. They recommend 12 months, which is what the data supports. Any progressive deformity or implant failure. I thought that all sounded pretty reasonable. And they said technique, bone graft, plate fixation, generally through an anterior pelvic approach. Didn't think that's necessarily wrong. I don't think it's always the right answer. And they even gave me a list of some resources, which some of what I thought were really great papers, and some they had not given all the other ones out of core that I really liked. So interesting. I don't think it's a useless tool, but interesting to see what it has to say out there. So non-union is definitely a risk after any elective osteotomy, and periacetabular osteotomy is not immune. I think you have to be patient because these can take up to 12 months, and you have to be transparent with the patient that we think these will likely, 90% of them are going to unite on their own. The repair has to follow all the same basic principles that any other fracture osteotomy surgery does. You got to give it the right stability and ensure it has the right biology. Thank you.